Okay. We're filming. Filming? Yes? Okay. All right, today going to be talking about bleeding control, the EMS provider. I don't know how many of you have experience. I know we're all EMTPs here, but Nancy right here, she just came to visit. Just going to give her some, brief reviews of what maybe she could do as a citizen to stop the bleeding before emergency services shows up, something along those lines. So it's going to be very basic, something that y'all are completely familiar with. All right, Angel. So bleeding control, what's the issue with bleeding control, right? What's the number one purpose of stopping a bleed, right? In a traumatic arrest, if it's because of a bleed, because some sort of severe accident, penetrating trauma, gunshot wound, laceration, amputation, we're not going to be doing anything until we stop the bleeding, okay? No point to do compressions if we're not stopping the bleeding, correct? So there's a number of different things that we can do. I guess first of which, can anybody really differentiate between a venous and arterial bleed? Can anybody tell me the difference? Spurting, oozing, shooting, and typically, what is the blood going to look like?
Darker arterial,
bright red.
Bright red arterial, darker venous. Okay. There's a number of ways we can stop the bleeding. Some of which, number one thing we can normally try is direct pressure, right? Typically, there's a couple different palpable arterial sites in the body, right? Just for people who really don't know that, the number one thing that we normally always look at is the radial, right? Where you take the radial pulse at. But there's a couple different ones. We have temporal, for example. We have axillary, which is the armpit, the brachial, where we take the blood pressure in a baby, okay? We have the radial, ulnar, we have the femoral here, popliteal, which is on the back of the knee, the posterior tibial, which is at the ankle, and the dorsalis pedialis, which is on the foot, okay? And the reason that is important is when we do a tourniquet application, we want to make sure we tighten the tourniquet to stop the bleeding until the distal pulse is no longer palpable, right? Usually, tourniquet application is going to be associated with extremity wounds, right? Lacerations, arterial bleed, leg or upper extremity arm or something along those lines. When we start talking about junctional wounds, which is proximal to the midline of the body, we're going to have to do wound packing, right? We can't really put a tourniquet up here on the femoral artery, okay? And that's a whole different scenario. So I'm going to repeat myself a couple times. Like I said, most frequent cause of preventable death from injury is a laceration, arterial bleed from a wound, okay? Like we said earlier, identify life-threatening bleeding would be spurting, wound that won't stop coming out. That could be a venous bleed too, right? Main difference with that, we can just apply pressure to see if that stops, right? If it doesn't stop and there's bleeding, everything's soaked, there's a pool of blood. We've all seen that before where the guy cut his own throat, right? Things along those lines, we're gonna hold direct pressure. On that one specifically, Angel, you know what I'm talking about. He walked in the kitchen and he was sitting in a pool of his own blood. And the cop actually had his hand and was stopping the bleed. The number one thing you never want to do is if a bleed is stopped like that, don't ask to look at it. Don't take pressure off of it, okay? The bleeding is stopped. That's the most important thing, all right? Next step in that is let's get the person to the hospital, okay? Because without surgery, we can't fix that. Talked about the torso or junctional wounds, which would be the neck, the shoulder, or the groin, right? This is probably the most dangerous one for firefighters using a chainsaw. That's why we always wear chaps, okay? If it's a junctional or torso wound, we're not going to be applying a tourniquet. We're going to do wound packing, right? We're going to be using Kerlix or 4x4s or something along those lines. I'll get there here in a second and show you what I'm talking about. So we can start off with direct pressure. You can use your hands or your fingers, right, if all possible. Direct pressure can stop even major arterial bleeds. I know in the field, like maybe in a hospital setting where you go in and you get a catheter to check your heart to get a couple stents, they used to go through the femoral artery here. I can tell you holding direct pressure on that femoral artery where they used to go on for 20 or 30 minutes will actually stop the bleeding, okay? That's another thing. If you have a laceration on the arm, which is arterial bleed, you might be able to hold pressure on the brachial artery that's a little farther up to put enough pressure there to stop the bleed, but you're not going to be able to hold that the entire ambulance ride, right? So more than likely they're going to need a tourniquet, right? All right. So let's talk about the tourniquet application at this point. So there's a couple different things that we have. So this is simple. This is just wound packing here. We have our typical 4x4s, right? That we have for wound packing for junctional and torso wounds and Kerlix, which we would also use for that, okay? We also have our CAT tourniquet that also fire department carries, all right? Pretty simple. I'm gonna give this to Angel. I'm gonna have him break it out and just kind of show everybody how to readjust it and put it back together. While he's doing that, these are pretty neat. The SWAT T tourniquets. It's basically like a giant inner tube, basically, okay? This is not what you typically want to use for a tourniquet, okay? But if you had to, this is definitely something you definitely want to use, okay? The number one mistake that people make with this is trying to put this on as a tourniquet, which we don't want to use as a tourniquet because we have the CAT T tourniquet here. When you're putting it on, you don't want to do a spiral like this, okay? That's a no-no. We don't want to do that, all right? We want to put it all in line, all direct pressure on the same spot. And tighten it and twist it as much as we can, okay? We don't want to do this on each other too, because this could cause some damage to students and other people. This is also good for after we do wound packings and pressure dressing, right? Because after I'm gonna demonstrate here in a second, after we pack the wounds for abdominal wound or junctional wound, somewhere where we can't use a tourniquet, this is what we're gonna use and wrap it all the way around for wound packing. Because it's great for pressure, okay? And this will hold it in place during transport to hopefully won't let that wound packing come off the artery that the bleeding has stopped. So right now, for arterial bleeding, I'm sorry guys, a couple different things. So for tourniquet placement, we want it proximal to the wound, at least 2 inches above or below the wound, okay? So example right here on this one, let's say we have an amputation of the lower extremity right here, okay? We're gonna do two inches at least away from the joint. And the reason we don't want to put it over the joint is because the bony structure of the joint will keep the tourniquet from compressing on that arterial artery, right? And we actually want to use the long bone of the humerus to put pressure against that arterial artery to help stop the bleeding. We use the bone to help stop, okay? So what Angel's doing here also, what we want to do, the number one important thing, he wants to tighten it until the bleeding stops. And then when the bleeding stops, he also wants us to check the distal pulses to make sure they're absent, right? That way we know the bleeding has stopped at this point in time. All right. And Julie, when we hear this in class also, okay, like if you're out riding around, you can actually buy these. We might give you one before you leave, okay? Did you see how he placed that? So you want to feel for the pulse, and you want to tighten it as tight as you can until the bleeding stops, okay? There has been situations that I've been in with a complete lower extremity amputation where we can't get the bleeding to stop. If that's the case, we can grab another tourniquet and place it right above this one and tighten it down until hopefully the bleeding stops. And that usually works, okay? We're gonna be putting these people in the back of the ambulance, taking them to the hospital as quick as possible also, right? What a lot of people don't talk about though is the tourniquet application. Whatever you do, once the bleeding stops, do not loosen it, okay? I guarantee you, if this person is conscious right here and we're putting a tourniquet on, they're gonna be screaming the entire time because it is extremely painful, okay? You have to understand, them screaming is probably a good thing if the bleeding is stopped, okay? You can tell them over and over again it's going to be really painful, but they're not going to have any idea how painful it is until you tighten it, okay? When the medics show up, they can give medications for the pain, all right? So let's talk about other guidelines as far as the tourniquet application goes. Number one thing, the doctors are always going to ask for in the hospital, they're going to want to know what time the tourniquet was put on, right? Because there's a 2-hour window that we don't want the tourniquet to be on longer than 2 hours, right? To the best of our ability, we want to find a Sharpie or just look at your watch, and the paramedics can write it down when they pick up the patient. Typically, we like to write the time when the tourniquet was placed right here, okay? And like I said, once the bleeding is stopped, we never want to loosen the tourniquet, ever, okay? Same thing with wound packing, or if you're holding pressure and the bleeding is stopped, don't let go until you know there's a tourniquet in place, okay? I've seen that happen before where somebody lets go after the bleeding is stopped before the tourniquet is even on the extremity, and then it starts spraying blood again, okay? We don't want that. Let's talk about some of the wound packing techniques, okay? Talked about this earlier. So basically the wound packing, I'm gonna give Lance these right here. That's just some regular 4x4s. This is gonna be some Kerlix, okay? So any sort of junctional wound, first off, let me just mention this. If we have any sort of severe bleeding coming out of the head, the last thing we ever want to do is put pressure to stop the bleeding on the head, okay? The only thing we can really do in that situation is just to lightly cover it, all right? We don't want to increase, we don't want to stop the head from completely bleeding because we don't want to increase the intracranial pressure in the brain, right? We want it to kind of bleed out. If you stop the pressure in the brain, the only way the pressure can relieve itself is by pushing out your brainstem or herniating down to your spinal cord, right? We don't want that. So just lightly put pressure and maybe wrap with a Kerlix. That's just the head, okay? Anywhere else on the body, let's say we're talking about junctional wound, even abdominal, like GSW, penetrating trauma, stab wound, steering column through somebody's chest or something along those lines. Hopefully you never see that. To the best of our ability, let's see if we can make a little, oh here. We're just gonna just push the Kerlix in like this, right? I've seen people just do a couple different ways like this and just keep pushing it in. You need 3 fingers to get in there, 3 fingers, right? I've seen other people do this. 1 or 2 fingers. It's a little harder on this dummy with 3-inch hose as a body because it's not very pliable like skin is, okay? But you just keep pushing it in like this. Just pack the wound as much as you can. And also, most arterioles or arteries in the body follow long bones, okay? So use the bottom of the long bone, all right, to pack the wound against that long bone on top of that artery, okay? And keep packing the wound as tight as it could go until the bleeding stops, all right? That's the most important thing. Once you get it packed, I've read a couple different things that say before they get to the hospital, if it's still bleeding, to remove the packing and then repack it. For us, we're not gonna do that. We're gonna leave the packing in and just apply more and more packing until we can get it to stop. That's when we can come up with the CAT-T tourniquet. And then we're gonna wrap it as tight as we can in place, especially before we move the patient. Andrew, you wanna hold that for me right there? We're gonna get it as tight as we can, that wound packing in place. Over that joint, over the wound packing, so the wound packing stays in place. See how tight that is? Feel that, Angel? That's pretty tight, okay? And we want that as tight as possible, as tight as we can get it, okay? Get this off real quick. Lance, I'm gonna give you this real quick. I just want you to, you wanna try the femoral one right here, or do you wanna try this over here?
Let's see.
That. Yeah, the pressure against the vessel is the most important component of hemorrhage control, okay? So like what Angel's doing over here, we want it as tight as possible. And as you can see with this, in real life situations, I've had people kicking themselves in their head with their own foot, okay? You're gonna need the help of at least 2 people, okay, to do this, all right? I've actually asked a police officer to hold the leg before while I was putting the tourniquet on, okay? Anybody on scene, even if a bystander, you can help us also, okay? So what Angel's doing here, this is just to hold the packing in place how we do the wound packing, right? Like I said, if this works for the arterial bleed, we'll do that. If not, we'll put the tourniquet, okay? But the amount of time we're spending on the wound packing here for arterial bleed, we're not gonna do that. We're gonna just put a tourniquet on and we're gonna load and go to the hospital, okay? That's more realistic. All right, so, find out. You did this real quick, right?
Especially if it covered in blood. It's gonna hold
Yeah.
it.
Does it get more traction when it's wet?
I don't know.
Okay, got it.
All right.
Yeah.
Don't wanna stop handling the pressure inside.
And of course, a couple things when we have somebody who has an amputation or severe bleeding, right? We're definitely going to want to do is monitor for shock. What are we going to do for that? If we can. If we have it, we're going to try to keep them warm, right? Number one thing. Most important thing though is we just want to get them to the hospital, okay? But we want to get them stable to the point that we're going to get them to the hospital. If we show up on scene and somebody has so much bleeding, right? No point in doing chest compressions until we stop the bleeding, okay? We're gonna have to stop the bleeding before we do chest compressions, okay? Let's focus on that, or we can do one at a time. What you don't wanna do, and I'm sure we've all done it, except for you, Angie, we've done compressions, and as we're doing compressions, we see blood coming out of the hole that's causing the penetrating trauma, right? It's ridiculous, you know? No point in doing that, okay? So the number one,
Are y'all training without him? Like,
It's
like
like
first off about.
I'm recording right now.
so hey LT, right now we're just talking about bleeding control. We're talking about tourniquet placements. We're talking about wound packing, okay?
Oh.
It'll be the number one preventable cause of death, right?
Yep.
And you know this, we go to traumatic arrest, right? Because of penetrating trauma, gunshot wound, stabbing, something, amputation. We want to stop the bleeding, but we start compressions, right? I'm sure you've seen it where people are pumping on chest and there's blood coming out of the hole,
Yeah.
right? We're not doing anything there. We're not priming the heart to shock it because there's no blood, right? You gotta stop the bleeding first, number one thing. Okay. Lance, have you tried the tourniquet yet?
Not.
Do y'all have a preference on like how y'all like to keep these stored on the unit? Angel, show me how you like to keep it stored on the unit. And this is just to make it a little quicker when we do have somebody that needs a tourniquet. It's a little quicker to put on and still be in a package.
It looks like you're reporting today.
No. Okay, so we went over the differences of how to apply the tourniquet, what wound packing is for, what extremities wound packing is for. Like I said, if you can stop a bleed initially with direct pressure, we can go ahead and do that. Typically, we're not going to do one wound packing for arterial bleed when we just drop a tourniquet on it a lot quicker, okay? That's just being realistic. And like I said, most important thing, once you stop the bleeding, do not take the tourniquet off, okay? Put a time on it right here. That's why this is great if you have a Sharpie. If not, don't worry about that. Just look at your watch and get like a best estimate, you know, within a couple minutes of when you put it on, because we don't want it on for longer than 2 hours. But within 2 hours, this patient's no longer going to be with us, all right? But at the hospital, it's the first thing that they're going to ask for, so. All right, does that, anybody have any questions? All right, thanks, Julie. Hope you learned something. I appreciate y'all. Y'all have a good day.